So to start us off with the presentation, I will pass it over to Paige Toshe to talk about infection prevention and control specifically in long-term care and retirement home sectors. So Paige, feel free to share your screen and I will pass it over to you.
Great, thank you. I just want to confirm you can see the slides okay.
Yeah, everything looks great.
Perfect. So thank you. Adele and I are the infection control professionals here at the Grey Bruce Health Unit and the Grey Bruce IPAC Hub, and we've put together a short presentation on infection prevention and control for long-term care and retirement homes, and the different roles of the Grey Bruce Health Unit and the Grey Bruce IPAC Hub. So just to begin, we wanted to take a moment to highlight the differences between our roles within the health unit and the IPAC hub separately. So the health unit is responsible for outbreak response and IPAC audits and inspections that are associated with these response. So if an outbreak is declared at your facility, we will be on site to complete an IPAC inspection. And then in terms of the health unit work as well, we also complete audits in response to various complaints or suspected IPAC lapses within Grey Bruce as well. For the IPAC Hub, on the other hand, this provides a variety of different services directly to congregate settings. So these congregate settings include, but are not limited to, long-term care homes, retirement homes, hospices, residential settings for adults and children funded by the Ministry of Children, Community and Social Services, or MCCSS, shelters, supportive and residential housing funded by the province. And these services are provided or required for congregate catchment areas based on the acuity of needs that are identified. So this slide just goes into a bit more detail and highlights some of the different services that are provided by the IPAC Hub, including education and training, supporting the development and implementation of outbreak management plans, connecting with community of practices, just to name a few. So the hub is able to identify and monitor IPAC training and practice needs within our catchment area of Grey Bruce, including in a variety of those congregate settings that are funded and overseen by the Ministry of Health, Ministry of Long-Term Care, Ministry of Seniors and Accessibility, MCCSS, and the Ministry of Municipal Affairs and Housing. So at the hub, we strengthen the current partnerships that we already have, and we broker new ones and support a network of various IPAC service providers and experts. So we work to align our resources to meet IPAC needs within these congregate settings for both prevention and response. And services are allocated based off of a risk-based framework. So now that we've outlined those different roles between the health unit side of things and the hub, we want to take some time to go over some key IPAC principles. So many of you have probably seen this hierarchy of controls before, but it highlights a range of different control measures that can be used. And as you can see, some are more effective than others. So the most effective control measure would be eliminating a hazard altogether, while PPE, on the other hand, is considered on the lower end and least effective. So regular and ongoing assessments of health and safety measures, IPAC checklists and processes, different auditing can help identify gaps and issues in some of these control measures so that they can be addressed. Completing some preparation and review in advance. So this could be in terms of reviewing isolation protocols within your facilities, having enough isolation and donning and doffing signage, an appropriate PPE supply, and even running through different mock exercises, the different situations that you might experience or you might run into will all be beneficial if you do end up in, for example, an outbreak situation that would require all of these to be in place. So the next thing that we want to highlight is the screening and surveillance aspect. So screening can be completed by anyone within a facility if they're trained to do so. The training is an important aspect to ensure that all steps of the screening process are followed. So when completing screening, these screeners should complete a point of care risk assessment so they can determine what PPE would be required for each interaction that they're having. And based off of the results of this risk assessment, they should be putting on the appropriate PPE. So this could include with a barrier. So for example, plexiglass, wearing a medical mask and eye protection as directed by ministry guidance. And then without a barrier, considering a medical mask, eye protection, which can be cleaned or changed if it becomes visibly soiled, wet, or damaged, for example. And then gloves and gown would be worn based off of that point of care risk assessment, and they're changed between each interaction if there is contact with someone who's being screened. So anyone who enters a building, so this could be healthcare workers, staff, essential visitors, general visitors, or even residents returning back from an off-site visit, with the exception of first responders, they are actively screened for those signs and symptoms and any exposure to COVID-19 when they enter the building. So this would be using the COVID-19 screening tool for long-term care and retirement homes that's available from the ministry. And it should be occurring 24/7 for this active screening. So in terms of the surveillance testing or the routine testing of those asymptomatic individuals that we mentioned above, so it could be healthcare workers, any visitors, things like that, is completed in accordance with the minister's directive. So it's important to remember that anyone who's completing this surveillance testing should be wearing the appropriate PPE and making sure that there's consideration to the location of this surveillance testing. So making sure that it's away from other activities. There's a separate designated area. If it's a smaller area, capacity limits, things like that should also be taken into consideration. So as I'm sure you're all aware, hand hygiene is the most important IPAC tool that we have at our disposal. So there's typically the two methods of hand hygiene. There's the alcohol-based hand rub and there's soap and water. So soap and water would be preferred when hands are visibly soiled in order to remove any of that debris, while alcohol-based hand rub is preferred when the hands are not visibly soiled. So one of the important things is to ensure that alcohol-based hand rub is easily accessible throughout a facility. So it should be available at all points of care and in all common areas as well. Just to make it easily accessible for both staff and residents to clean their hands and practice good hand hygiene. So we just wanted to highlight again the importance of the 4 moments for hand hygiene. So this would be before initial resident or resident environment contact, before any aseptic procedures, after any body fluid exposure risk, and then also after a resident or resident environment contact. So it's important to keep these 4 moments in mind as well. And then just as the last point in terms of hand hygiene, we want to emphasize that glove use doesn't replace the need for appropriate hand hygiene. So hands should be washed before putting on a new pair of gloves and also after taking off a pair of gloves. And alcohol-based hand rub should never be used in gloved hands. So PPE is another important component of IPAC. Which PPE is required is based on routine practices, additional precautions, and a point of care risk assessment. So routine practices is under the assumption that everyone may be carrying harmful microorganisms regardless of their isolation status or diagnosis, and they're followed all of the time. So this includes things like hand hygiene, PPE being used appropriately and when needed, cleaning and disinfecting of shared equipment, and environmental cleaning. Additional precautions, on the other hand, are used in addition to those routine practices, and the types of precautions depends on the suspected transmission. So they could be droplet, contact, airborne, or a combination of these precautions. So in terms of COVID-19, droplet contact precautions are the additional precautions that are required if someone is suspected or confirmed to have COVID-19. Given the uncertainty around the Omicron variant, Public Health Ontario has released interim IPAC recommendations for the use of PPE for the care of these individuals with suspected or confirmed COVID. And this guidance outlines the use of N95 for the direct care of these individuals. And ideally, staff should be fit tested for these N95 masks. And to connect back to this, although the PPE itself is an important consideration, it's also super important to follow the appropriate steps for donning and doffing. So having the appropriate signage on isolation room doors is very important. It reminds staff of the appropriate steps and just gives that visual reminder that they can follow when they're putting on and taking off their PPE. So ideally, the donning sign should be on the outside of the resident's door where staff would be putting on their PPE, and then the doffing sign would be on the inside of the door when the PPE is being removed just before exiting the room. Homes should also consider completing a burn rate calculator in order to determine the appropriateness of their supply of PPE given an outbreak scenario. So it's recommended to complete this in advance. So the situation of potentially running out of a supply of certain PPE, if in an outbreak situation where it's used up at a quicker rate, doesn't occur. So when an individual is placed in those droplet contact precautions, another consideration is making sure that those isolation carts are available for each room. So these carts should be stocked with appropriate PPE that's required to enter each of these rooms, along with that alcohol-based hand rub and disinfectant wipes to disinfect things like reusable eye protection if that's being used within your facility after leaving one of these isolation rooms. And it's important to have these carts fully stocked at all times and available outside of the residents' rooms, and making sure that that PPE is stored in a way that keeps it dry and clean as well. And then the last thing we just want to touch on is in terms of laundry and garbage for the disposal of used PPE, it should be stored just inside the exit of the resident's room so that wherever possible, PPE is removed and hand hygiene is performed at the exit of the room. So again, it's important to have that alcohol-based hand rub available in order to do so as well. So we won't go into too much detail on this slide, but we wanted to highlight these tables from that Public Health Ontario interim IPAC recommendations for the use of PPE for the care of suspected or confirmed COVID. So these tables highlight what individuals should be wearing during different activities being completed in long-term care and retirement homes, and it's a great reference document. So in terms of environmental cleaning, we wanted to touch on a few points. So products that are being used for that disinfection should always be the Health Canada approved product and have that DIN number. So a home can use any product that does meet this requirement, but they should always follow the manufacturer's instructions for things like contact time, concentration, etc. It's also important to note that some products are available as ready-to-use products, while others require some additional preparation steps in order to ensure that they are at the appropriate concentration. So just making sure that everyone who's using a disinfectant within a home has received some sort of training and education, and they're aware of these instructions for use as well. So they're aware of the contact time for the product that's being used, so they know how long the surface has to remain wet when they're using that disinfectant. There's also different methods for disinfection. The most common are the bucket and cloth with no double dipping, wipes. Aerosol and spray bottles are another option, but they're not typically recommended because of the occupational health and safety considerations with potentially breathing in some of these aerosolized chemicals. So this diagram outlines some additional considerations when choosing which product to use and when to use it. There's a lot of products out there, and we've already discussed some of these related to the ease of use, but other considerations include the efficacy of the disinfectant that you're using in killing whatever pathogen it needs to, how compatible it is with different equipment or surfaces that it's being used on, and also how safe it is to use. So looking at things like respiratory or skin irritants for staff who could be using the product, flammability, food safe if it's being used in a kitchen or dining area, for example, and then the different PPE requirements that would be required for whatever products you're using. And then a final consideration is also the cost and the environmental impact of the product. So this could be taking into consideration whether the product's biodegradable and safe for the environment as well. One additional thing to highlight when choosing a product is distinguishing between that cleaner and a disinfectant. So a cleaner will physically remove any foreign or organic material rather than killing microorganisms. So it's accomplished with water, a detergent, and usually mechanical action. Whereas disinfection is the actual inactivation of any disease-producing microorganisms. So medical equipment, any surfaces, any devices must be thoroughly cleaned before disinfection takes place in order for the disinfection to be effective. And there are products out there that are a combined cleaner and disinfectant, so it can be used for both steps. Just follow the manufacturer's instructions for whatever they recommend. And then the last thing that we want to touch on is auditing. So auditing is an important infection prevention and control tool. It can be used to highlight any issues or provide an opportunity for any on-the-spot training or refresher education related to any gaps that are identified. So auditing can be done for hand hygiene, environmental cleaning, PPE use, which can include the appropriate use of PPE. So making sure that a mask is covering your nose, mouth, and chin at all times, that gloves are being changed when appropriate, things like that. And then it can also be used for making sure that the appropriate steps are followed for donning and doffing. And then we also just want to highlight the importance of conducting regular overall IPAC self-audits within your facilities using the PHO checklist that's outlined in Directive 3. So regular IPAC self-audits should be completed within your facilities at a minimum every 2 weeks when a home is not in outbreak, and once a week when a home is in outbreak, to identify and address any gaps in IPAC practices within your facilities. So homes should be following the Ministry of Health's COVID-19 guidance, long-term care and retirement homes for public health, the most recent version, for more detailed requirements and information sort of relating to these IPAC audits. So that's the end of our presentation for now. Thank you. I think we might be leaving the questions until the end, but if you have any, you can always put them in the chat box for now. Thank you.
Wonderful. Thanks so much, Paige. Yes, so if you do have any questions that you would like addressed immediately, feel free to enter them in the chat box. We'll do our best to get to those. However, we should also have some time at the end of this chat to answer any and all questions that the group may have. We will pass it over right now to Dr. Zayed, who will discuss some details about the COVID-19 vaccine specific for our long-term care and retirement home sector. So Dr. Zayed, I'll pass it to you to share your screen. Thank you very much.
Thank you. Good morning, everyone. Thank you for joining today. I'm going to share my screen. Let me know if you are seeing my screen right now.
Yes, we see your screen.
Thank you. So first, I want to mention that I really, and we as a team here in Grey Bruce Health Unit, we appreciate the collaboration, time, and effort that you are putting in this critical time, and we are here to support you. I'm going to talk today about a vaccine overview for long-term care and in Grey Bruce in general, as well as in touching on the vaccine hesitancy as well, and some few points that are of importance to you. So the main point I'm going to touch on today is the uptake percentage, the vaccine administration, factors associated with vaccine hesitancy, vaccine and Omicron context, and impact of vaccine on the disease. So if we talk about the Grey Bruce in general, community-wide, we have, so this is from age 5 plus, we have the, according to the geography, the areas of uptake after 2 doses. And we can see that the uptake in some areas are 85%, even some area are 90%, 91%. There are still some area of low coverage. So. And this is after 3 doses, again, after the booster. There are we can see that there are some areas of low coverage. And as we completed the mass immunization clinics, we will focus in our next plan for vaccine on the low coverage areas in addition to school. So that's just an overview of the vaccine situation. Age-wise, if we talk about long-term care facilities, long-term care residents and long-term care staff, there are, this is the coverage by age. So the coverage from 65 onwards is really good overall. There are some areas when as you can see here, it's above 100%, but this is because there is in the document, some people have two addresses or in the border, so they are documented twice in two house units. But overall, the vaccine above 65 is really have a good coverage. We can see here still the staff in overall is also the percentage for 2 doses and 1 dose is above the 85%, but there are still some area where staff ranges from below around the 60%. So there is, we have noted that there is discrepancy between the staff vaccine uptake versus the residents uptake. This is how the vaccine in long-term care is recorded. So there is a vaccination event based on and the date given and the number of doses given as well. These are some overall recommendation about the doses. So as you know, we will roll out the 4th doses is now as it is now recommended for residents of long-term care homes, licensed retirement homes, elder care lodges, and older adults living in other congregate settings, providing assisted living and health services. This population will be eligible, and it is exactly 84 days or 3 months after the 3rd dose. The 4th dose are prioritized for settings, for these settings for resident, and 3rd doses are prioritized for staff, volunteers, contractors, students, visitors, support workers, and essential caregivers. Preferred use of Moderna Spikevax for this population. However, there are also availability of other vaccines. Independent administration by homes is a method of delivery. However, we also support any other method of delivery in this in long-term care. Public health units are expected to have vaccine available for homes for pickup within 3 business days and delivered within 5 business days once an order is placed. Of course, we know the situation of the outbreak. So once an outbreak is declared over, or with our continuous communication, we can assess the delivery of vaccine as soon as possible. These are some questions that have been raised and compiled by the Ministry of Health that I think also would be helpful. So some of these questions related, or they are all related to the vaccine. So can someone below age of 70 residing in an eligible congregate setting receive a 4th dose of Moderna? And so residents in the eligible congregate settings are recommended to receive Moderna 100 microgram with clinical discretion. If the client is younger, they can receive the dosing based on clinical discretion as well. If an ALC patient is in transition to a long-term care home, can they receive a 4th dose? Yes, they may receive a dose if the facility they are in are able to administer the dose. For example, from hospital to long-term care. A resident does not want an mRNA vaccine as a 4th booster and have requested a viral vector instead. Can they receive a viral vector 4th dose? It is recommended for the better immunity to have an mRNA as a booster, but if the individual requested a special vaccine, a viral vector dose for a 3rd dose or a 4th dose, this request can be submitted to the public health units and to be completed and to identify the best method for this individual to receive a viral vector dose. And another question about the single dose vaccine that are available now for some population. So this is a single dose. How does that work as a third or fourth dose? So a single dose is considered a primary series, and anything after as this single dose is considered a booster, either third or fourth dose for this population. What is the minimum age of administration of a fourth dose? Again, there is no age requirement to receive the fourth dose. The eligibility is that a person is a resident or in transition to be an eligible setting. Other congregate settings are only eligible if the residents are older adults. Older adults are deemed to be 65, but a fourth dose booster can be administered to any resident that resides with older adults as per clinical discretion. Are naturally occurring retirement communities included for rollout? So naturally occurring retirement communities are communities that are like neighborhood where there are more elderly population. So they are not considered congregate setting and not natural and are not included in the rollout at this time. Will there be any changes in the booking appointment related to booking capabilities for this population? There will be no changes since the administration will be happening within the eligible setting, meaning the congregate setting. This is just a quick cheat sheet for the vaccine dosage. So for 70 plus, they are having Pfizer or Moderna full dose for the booster, and from 30 to 69 they are eligible for Pfizer or Moderna half dose. From 18 to 29 is Pfizer and Moderna half dose, and Pfizer is preferred. It was based on the availability, but I think right now this has been is accessible for everyone. And as you see here in 70 plus, the Moderna, the fourth dose is the Moderna full dose because of the reduced immunity in this vulnerable population. And some of them are also have comorbidities. So with the context of Omicron, it was found that Moderna, the full dose is important. And I will come to that in following slide. When we talk about the vaccine hesitancy, I think I just wanted to touch on that. So it is a delay in acceptance or refusal of vaccines despite availability of vaccine services. And this is understandable in some situations because vaccines different from other intervention, it is generally offered to individuals who are healthy, as opposed to other health interventions that predominantly are intended to people with a disease. And of course, it's more than any other vaccine, more than the flu or the usual conventional vaccine, routine vaccines. The COVID vaccine has triggered a lot of hesitancy. I just also want to touch base on the main reasons for this hesitancy. So it is compiled in this 4C acronyms: complacency, where there is a lack of experience with the vaccine preventable disease. Vaccines are not really considered important because in the perspective of some population, because they don't see the diseases now as the same way as it was before, like they don't see enough cases of polio or enough cases of measles to really understand the seriousness of or the impact of prevention that the vaccine have impacted our life to a better so that we don't see these diseases. Convenience is access or time or priority. And basically we are working on that so that We are trying to, as you see, we divide the vaccine based on geography or based on the uptake based on geography. So we are trying to provide this convenience in terms of access, the equitable access, the time, different time, so that it can be convenient to anyone to get the vaccine, and prioritize it in different situations. For example, for vulnerable population, for people who are working in high-risk settings. So we are our focus is really on this convenience as a barrier to reduce this barrier. In terms of confidence as fear, past experiences, feeling intimidated, perceived risk and benefit, acute risk benefits with APHIS. So we are also trying to work on that one, but basically on individual level, case by case. But it is very important for the clinician or the healthcare provider to understand the underlying factors behind the hesitancy. There are also the force factor, or the force C, which is a culture. This one is really the most maybe complicated one, with religious beliefs, social context, media influencers, and we can see now the effect of social media on how they polarized the people towards a certain unfounded, sometimes unfounded situation. And if you even Google or see the web browsers, the first things that you can tap is sometimes an anti-vaccine site. So it is really an important thing to understand and explore with patients or clients. And the main thing is really the most important thing is for those who are on the fence ideologically or culturally, is to provide evidence and provide the safety evidence for the vaccine. Of course, there is other distrust things, so in the health system or in the government. So it is overall what I want to say from this one is we need to understand the cause behind it so that we can address it. The next couple of slides is really about how the Omicron context and the importance of vaccines. So we heard a lot of people saying, since now the infection is really less severe, there is no need for getting the vaccine, or if everyone is getting the vaccine, everyone is getting the infection and it's just common cold. So it is really not important. The vaccine has no role now. And this is also something that that needs to be addressed and discussed, and to know if it is really true or not. So I would imagine the same situation that we are in right now with the Omicron and this surge of cases, like 1 year back with the Delta, for example, and the amount of severity and the overwhelming health, how this health system became overwhelmed at this time. We don't have this situation right now, thanks for the vaccines. We really have to remember and remind ourselves for that. If not for vaccines, we would have been in a continuous critical situation. This is a recent slide from the science table, and it shows here the effect of Omicron, of infection, ICU, and hospital. So you can see here after 2 doses, and this is in patients who at least had 2 doses, 2 vaccine doses. So as you see in the dates here in August, September, October, things were really good in terms of prevention and protection. And all of a sudden in December, around end of November and December, we had this drop of protection where many people have been infected, even with who had 2 doses of vaccines. And this is because there was this vaccine skipping organism, which is the Omicron, and many people have been infected. And then after that, when people, we got again an increase from end of December, first week of January, an increase in the protection again. And this might be due to people started to get the third dose, and people started to also work with like make sure get again more precaution. In addition, of course, to those who have been infected, but there is more protection now, and we can see that with less number of case count, less number of also of decreasing the positivity. How about the ICU and hospitalization? So this is more pronounced than the infection. It is that we can see here the ICU after for vaccinated, at least for 2 vaccine doses, is continued to be high for the protection wise, and same is for hospitalization. It has a little bit of a drop, but not really a severe drop. So this was really like a self-explanatory slide about the importance of vaccine, of at least 2 vaccine doses. And that's why we worked on the booster and the first dose for our elderly population. For this slide also, it shows here cases among, this is a comparison between unvaccinated and vaccinated. So you can see here, for the number of cases of unvaccinated, the number of cases is higher, and compared to the vaccinated for at least 2 doses, it's almost double or more than double. The other here, which is more important again, is vaccinated hospitalization. So this is the number of vaccinated hospitalized individual with at least 2 doses, and this is the unvaccinated. So it is 5 times higher. In addition to the severity, like we almost see more death and severity in unvaccinated. And we don't see any cases in vaccinated that is really severe unless there is other severe comorbidities. And again here, the cases among unvaccinated individual and unvaccinated individual compared to cases who are at least vaccinated with 2 doses. And same as the gap here between hospital occupancy among people with vaccinated at least 2 doses compared to hospital occupancy, which is still increasing for unvaccinated individuals. With that, I come to the conclusion of my presentation, and as always, we are here in Grey Bruce Health Unit to support you with the best of our ability. And thank you for your attention, and happy to answer any question.
Perfect. Thanks so much, Dr. Zayed. If anyone does have any questions, again, feel free to enter them into the chat box, and we will definitely get right to those if they come in, and we're able to take care of those in real time. If not, we will again have time at the end of this presentation to discuss any questions or concerns. All right, so we will just keep on moving. And next, I would like to introduce Jillian Jordan, who is a Public Health Manager of the Infectious Disease Department here at the Public Health Unit, who will discuss a little bit about infectious disease and case management, specifically related to COVID in long-term care homes and retirement. So I will pass it over to you, Jillian.
Great. So since we've seen so much change in guidance since back in December when we were working through primarily Delta, we wanted to just give a quick overview as to where the current guidance is sitting for case and contact management for COVID-19 in the face of Omicron, and then how that rolls into outbreak management for long-term care and retirement homes. So there are Several key guiding documents that I'm sure we're all referencing frequently. These are subject to change, and I think we are expecting some upcoming changes to some of the key ones, including the case and contact management guidance, as well as the recent released guidance for long-term care and retirement homes for public health, which really focuses on outbreak management. So presentation today is based on current guidance, and keep an eye out for new and upcoming changes. So since the end of December and into early January, we've seen some really major changes to our case and contact management guidance, primarily around how the public is treated for testing as well as case and contact management. So a big change to the guidance has been who is eligible for testing. And right now, testing is focused on prioritized individuals and groups. So that includes volunteers, residents, essential care providers, and visitors in highest high-risk settings, such as long-term care and retirement homes, as well as their household members. And the goal of this prioritized testing is to hopefully see quicker test results for those who need them most. We have heard that turnaround time for testing has been challenging over the past few weeks, though labs are reporting their Christmas backlogs are starting to resolve. So hopefully we'll get back to that closer 24 to 48 hour turnaround time that we knew before the surge. So for everyone else that isn't eligible for testing, the advice for general community members is that if they're symptomatic or if they self-test positive on a RAT test, so rapid antigen tests, they're advised to assume that they're most likely positive for COVID and to isolate and manage as such. So a case themselves will isolate for 5 to 10 days, depending on their situation, and their household members isolate alongside. So isolation period is also something that's changed since back in December. For fully vaccinated individuals or people under 12, the current isolation period is 5 days plus a 5-day caution period. So those who are eligible for the 5-day isolation are advised that from days 6 to 10, wear appropriate PPE if out and about, and avoid visiting immunocompromised individuals or working or visiting in high-risk settings, which we do see then specifically in case management guidance for folks in long-term care and retirement. Unvaccinated individuals or those who are immunocompromised or hospitalized are still isolating for 10 days based on that symptom onset or the date of their positive test result, whichever is first. And just to remind folks that for cases who either test positive or even in the community test positive on RAT or are symptomatic, we generally don't require a negative test or any sort of letter or formal documentation to end that isolation period. So if you do have a staff member with a positive test result, their 10 days has elapsed, they don't require a letter or anything to formally end their isolation. So generally, high-risk contacts of cases, such as in the household, will isolate alongside the case for the length of time that the case's isolation is, unless the household member themselves develops symptoms, in which case their isolation period starts for 5 to 10 days, depending on their situation. This is a bit different for close contacts, so non-cases, but exposed to a case, in people in highest high-risk settings. So if someone is a high-risk contact, they're generally looking to isolate for that full 10 days or self-monitor for 10 days outside of the high-risk setting. So this definitely is more conservative than the guidance that's given to our general community members. As far as how we're managing cases and case investigations here at Grey Bruce Health Unit, now that we're seeing a bit more reasonable numbers down from our 100 plus over the Christmas season, we are back to doing direct calls to all confirmed cases. So people who received a PCR test results, which are reported to us, to do a bit more investigation to see why they were tested and where they might be. Generally, when we do receive results for folks under 16 years of age or people who have clearly recently traveled, we do still refer those on to the virtual assessment tool, which is what cases throughout December and early January would have received, which still gives them an opportunity to disclose a high-risk setting involvement, in which case we do our full follow-up. In the event that we do have a positive PCR in a case within our area, we do a focused investigation to try and identify high-risk setting involvement, so a staff or visitor at a long-term care retirement home, determine acquisition, so where they might have been exposed within the 10 days before symptom onset or positive test results, determining where they could have transmitted the infection, so if they'd been working during their POC or again visiting the long-term care home, and then risk to the long-term care home or retirement home themselves. So looking at what that person did when they were potentially contagious, so where they worked, what their role is, PPE, interactions with colleagues, both inside the home as well as outside, and then filtering that information onto our infectious diseases or outbreak management team. So we have been advising anyone who works within these settings, if looking to talk about early return to work, so returning to work prior to whether their isolation period as a high-risk contact or a case, that this needs to be discussed with their workplace, and then their workplace in turn discussing with public health, rather than leaving that up to a discussion with the case investigator. We do know that some healthcare workers that receive their health or their COVID counseling or investigation from health units outside Grey Bruce may receive different information, but wherever possible, we like to leave those conversations, like I said, to the employer and the employee themselves. So now that we have the case management piece kind of out of the way, shifting more into how outbreaks are triggered or managed here in the face of COVID. So in the pre-outbreak period, the first real piece is triggering an investigation. So we're starting to deviate from our normal in that we're maybe noticing new resident illness, staff illness, we're seeing positive lab results for COVID or other things flowing through the home, or we flagged an exposure event of interest. So someone positive, potentially positive, coming through the home. And pre-outbreak assessment might be triggered also when we identify need for resident testing, especially if a resident is showing any new or unusual symptoms. And something new in the guidance within the last few weeks is the opportunity for all new symptomatic residents to be swabbed for COVID, which has been the case, as well as full respiratory panel. So anytime someone's newly symptomatic within the home, you're able to order that full spectrum of testing to see what's going on. When you move into outbreak territory, though, that will be limited to 4 samples once an agent is identified. So as we identify ill residents or staff or folks with positive test results, we're moving into outbreak territory. And there are 2 sets of definitions that we're currently working with. So our classic pre-COVID outbreak definitions, which generally triggers an outbreak if there are 2+ cases of illness or a single case of influenza within a specific time period within a generally confined area with an epi-link. So really, we're looking for evidence of transmission within the home. For COVID, the definitions are a bit more flexible, and current guidance suggests that a suspect COVID outbreak is a single positive case in a resident. So that could be positive by PCR, rapid antigen, or our rapid molecular tests like an ID now, with it confirmed being 2 or more residents or staff within 10 days, which is that incubation period with an epi-link. So again, looking for evidence of transmission within the home environment. However, we have been declaring outbreaks based on various scenarios as they arise, just to trigger those increased measures to help to ensure safety within the home, as well as facilitate that extra testing, just to get a picture of if COVID is there, how much of it, and to make sure that we're adjusting our outbreak measures as appropriate. So public health will declare an outbreak depending on what we find from our investigation and the information you share with us to the level of risk we think the situation is presenting. So in doing our outbreak risk assessment, we're really looking to identify the source or acquisition. So how did COVID get there? Is from inside the home, outside of the home, or unknown? how transmission is happening. So commonly we're seeing staff to staff right now, but is there evidence of staff to resident, resident to resident, or again, if that transmission is unknown? Trying to flag an impacted area, identifying who is high risk as a contact, so has been in close proximity with a confirmed case, unprotected for a certain period of time. We can establish that, great. Sometimes we can't, as well as looking at other risk-related factors, so vaccine coverage, PPE compliance, in order to judge the extent of outbreak measures needed in order to provide that advice. So some common measures we'll put in place depending on the situation starts from a baseline of really enhanced surveillance. So that frequent and thorough health status screening of residents and staff, as well as isolating and testing any new symptomatic residents. For testing, of course, we're always testing any new symptomatic residents for COVID, as well as now the opportunity for the full respiratory panel. But in outbreak situations, we'll also advise asymptomatic testing of residents and staff. And that is really to get a picture of, like I said, how much COVID is there, to better know who's a case, who's a contact, and again, adjust our outbreak measures as needed. So generally, testing is advised for all residents as soon as possible when an outbreak is declared. That's a confirmed outbreak. And then we generally repeat that testing within a couple days after isolation has occurred, just to identify any ongoing transmission or exposures. So if we see a couple rounds of testing where we're not identifying any additional cases, we will pull back on that testing. But that frequent testing across the board does help us to get a good picture of, whether exposure or transmission is ongoing. Additional measures in outbreak situations are isolation of cases and high-risk contacts. So isolation of cases is pretty straightforward. Those who are positive for COVID or in the event of other respiratory illnesses, isolated as well for the prescribed amount of time. Where there is a different practice for COVID is isolating those also who are asymptomatic. So wherever possible, we like to identify those who are actually high-risk contacts, as in having a potential risk of exposure, for 10 days from their last exposure, based on the most current guidance. What we do find tricky is in communal living settings, if we're not able to identify who has been in close contact, often this isolation will be triggered across the impacted ward, unit, facility, seeing most residents isolate for those 10 days. If once in isolation, we continue to see new cases pop up and we're questioning ongoing exposure, that isolation period may be continued, but it is really our goal to see folks out of isolation as soon as possible if it can be safely done. And then just within an outbreak facility, staff who have been using appropriate PPE would generally not be considered high-risk contacts, which facilitates their ability to work within the home during an outbreak versus that 10-day isolation period or monitoring period outside the home. However, we have seen instances where staff to staff transmission is occurring through, say, social gatherings in or outside the home, getting too close during breaks or carpooling, in which case we may be advising a high-risk contact of a positive staff member to isolate or self-monitor outside the home just to minimize that risk. So related to staff as cases and high-risk contacts, we do know that staffing shortages continue to be a concern across the board, and that in certain instances, having a staff away from work for the full 10 days, which we like to say wherever possible, is quite difficult. So with early staff return to work, as well as having staff work between two outbreak facilities or admitting new residents, say during an outbreak setting or situation, we like to start with the lowest risk option as possible. So wherever we can avoid having to bring people back positive or people back early who may be positive or high risk contacts, we like to avoid. If we do need that based on a critical situation, working through the lowest risk option first and trying to, avoid introducing any unneeded risk. So if you're finding yourself in a place where introducing a bit of risk is the only way things are going to keep going. We just advise to reach out to our team here and chat through the different situations and scenarios. Often there'll be a couple options and we can help discuss which one might be the best to introduce the least amount of risk. New guidance 2 also updates the end of outbreak period to 10 days versus 14, as we were seeing before. So really, once a home's in outbreak, in order to declare it over, we're looking for kind of 10 clear days. So whether that be 10 days from the date of self-isolation for the last resident or staff, or the last illness onset of a resident, after 10 days of no activity, can declare that outbreak over in consultation with your ID team member. And for those who've been in outbreak for a while, it is worth reviewing that Public Health Ontario de-escalation document for outbreak control measures to smoothly transition outside your outbreak response. So that is my summary of those key points for case and outbreak management as it's related to COVID. So continue to reach out to us. We have restructured our team in order to try and serve you best. We've divided our homes up into several different columns, so you'll be getting more familiar with your leads as we work through these outbreak investigations. And as always, Monday to Friday, 8:30 to 4:30 for an urgent response. Call us at extension 6, which is our helpline. Okay, thank you.
Wonderful. Thanks so much, Jillian. And as usual, if you do have any questions, please enter them in the chat box. And once we get through Nick's presentation that will be next, we should have a few minutes as well if there are any questions that arise at that point in time. So I will pass it over to Nick Lovell, who will talk specifically about the legal roles of public health and long-term care in long-term care and retirement homes, specifically related to the Health Protection and Promotion Act. So without further ado, I will pass it over to you, Nick. Feel free to share your screen and take it over.
Thank you, Ian. Good afternoon, I guess, everyone. This is going to be a presentation going over the legal responsibilities that public health has during a pandemic, specifically focusing on their statutory powers. Hopefully this will just be a refresher as for the first time in quite a while, the public at large has had to experience some of these things, but I'm going to go over sort of the foundational framework of that. The Health Protection and Promotion Act is an Ontario statute that does a number of things. It creates the public health authorities in Ontario. It establishes their governance model and jurisdiction, and it grants those agencies authority over things like health hazards, small drinking water systems, inspection of food premises, tattoo and jewelry stores, communicable diseases, public pools, and a host of other things. As I've said before, this is a role that public health has fulfilled for many, many years and is not widely known to the public because when everything is working properly, you don't really know that they're doing anything at all. So the hierarchy of authority that's created under the statute is first the Chief Medical Officer of Health, which is now Dr. Moore, then regional boards of health, finally the Medical Officer of Health as the statutory framework, and from there the health unit itself has its own internal hierarchy of directors, managers, inspectors, and other employees. So the Chief Medical Officer of Health is a defined role with specific authority, and in particular, the Chief Medical Officer of Health can require the adoption or implementation of policies concerning infectious diseases, health hazards, public health emergencies, and other matters prescribed by the government, provided that they are of the opinion that there exists an immediate risk of a provincial, national, or international public health event, a pandemic, or an emergency with health impacts anywhere in Ontario, and that the policy measures are necessary to support a coordinated response to the situation referred to. When these directives or policies are issued, a board of health or medical officer of health that is served with that direction has to comply with it. From there, we have the boards of health. Our board of health is for Grey Bruce as a whole. They exist in each geographic region specified. So as I said, it's the 2 counties for us. Other regions are bigger or smaller, depending on what the government chose. And the Board of Health has responsibilities for things like finance, so banking, auditing, appointment of officers, ensuring that the health unit carries out its obligations under the Act, and appointing a medical officer of health. To that end, a medical officer of health has specific requirements to be appointed. They have to be a physician. They have to possess any qualifications and requirements prescribed by the government, and then they have to be approved by the minister. So when a Board of Health selects a candidate, that candidate is submitted to the ministry for final approval. A medical officer of health has defined responsibilities. They are directly to report to the Board of Health on any issues related to public health concerns, public health programs, or services that public health provides under the Health Protection and Promotion Act. They are effectively the CEO for all of the employees of the health unit and are responsible for overseeing those duties and the delivery of public health programs and services. They are responsible for management of public health programs and services. And then finally, and importantly, the authority of a medical officer of health under the Act is limited to the geographic region that they are serving in. So our medical officer of health only has jurisdiction over Grey Bruce, and then other medical officers of health in the province of Ontario do not have jurisdiction over our area. I'm going to focus more specifically on communicable diseases for the rest of the presentation. So it's helpful to define what exactly a communicable disease is. So a communicable disease is any disease as determined by the Ontario government. And the Ontario government actually publishes a list of what is a communicable disease. For the context of this pandemic, novel coronaviruses are considered to be a communicable disease. The medical officer of health has authority to issue orders that deal with communicable diseases, provided that they meet three criteria. One, that there is a communicable disease that exists or may exist, and there is an immediate risk of an outbreak of the communicable disease, that this disease presents a risk to the health of persons in Grey Bruce, and that the requirements specified in the order that they make are necessary in order to decrease or eliminate the risk to health presented by the disease. Once they've satisfied those three criteria, the medical officer of health can make an order to compel or restrain people from doing certain things. In particular, they are explicitly allowed to require someone to close a premises, to provide public notice of that closure, requiring a person to state that they may have a communicable disease and isolate themselves, requiring cleaning or disinfecting or both of premises or other things, requiring the destruction of any matter or things specified, requiring someone to submit to an examination by a physician, and otherwise requiring someone to conduct themselves in a manner that will limit the exposure of another person to infection. So those itemized things are specifically included in things that an order can do, but what is actually said in the Act is that an order can include, but is not limited to these things. So the overarching limit on what an order can do generally is whether or not it decreases or eliminates the risk to health. Moving on from specific orders, there are reporting requirements for communicable diseases. So any physician or member of the College of Chiropractors, dental surgeons, nurses, pharmacists, optometrists, naturopaths must report to the medical officer of health any person whom they are of the opinion has or may have a disease of public health significance, unless that person is a patient, an inpatient or outpatient of the hospital, provided that the listed professional is providing professional services. What this means is a nurse or physician providing professional services must report any person whom they are of the opinion may be infected with COVID-19 as soon as possible after forming that opinion. The only exception to this rule is an inpatient or outpatient of a hospital. For our audience today, there is no exception explicitly for long-term care residents. So if they are just a resident of long-term care, physicians and nurses have a reporting obligation. Where they are an inpatient or outpatient, it is the responsibility of the administrator of the hospital to report any potential cases of COVID-19. In addition to individual physicians and hospitals, schools have a similar reporting requirement for any students that the principal has reason to believe may have COVID-19. And then again, for our purposes today, institutions have this reporting requirement. And in this case, it's the superintendent of an institution that shall report to the medical officer of health any entry in any records that indicate a person has or may have a disease of public health significance or is infected with a communicable disease. And they shall do this as soon as possible after entry is made into the records of the institution. So what is an institution? That is also defined, and an institution includes a number of things, including child and family services, children's residences, child care centers, homes for special care, psychiatric facilities, correctional facilities, detention facilities, private hospitals, and for our audience today, long-term care homes. So the requirement is the superintendent of a long-term care home must advise the medical officer of health of any known or suspected cases of COVID-19 as soon as possible. Superintendent in this case is defined as a person who has for the time being direct and actual superintendence and charge of an institution. So this would be the most senior person working at the time who has effective institutional control. In addition to orders against individuals, the medical officer of health can make orders requiring a public hospital or institution to take any action specified in an order for the purpose of monitoring, investigating, and responding to an outbreak of a communicable disease, where the medical officer of health is of the opinion on reasonable and probable grounds that an outbreak of a communicable disease exists or may exist, that the disease presents a risk to the health of the persons therein, and again, that the measures in the order are necessary to decrease or eliminate the risks to the health associated with the outbreak. So, determinations of an outbreak at a long-term care home are done at the discretion of the medical officer of health. It is their sole statutory responsibility to do that, and when they do, this tool of an order and the potential effects that it can have become available to that medical officer of health. In addition to providing requirements, the Health Protection and Promotion Act creates offenses for non-compliance with the Act. These include failing to obey an order made by the medical officer of health, failing to report a communicable disease, and obstruction. So that naturally leads to the question of what is obstruction, and it is hindering or obstructing an inspector appointed by the ministry, medical officer of health, or a public health inspector, or a person acting under the direction of the medical officer of health, lawfully carrying out a power, duty, or direction under this act. So interfering with the inspection powers that public health has. Where this is done in addition to an offense, public health can obtain a warrant compelling cooperation where an inspector has been denied entry, instructed to leave, obstructed, or has been refused production of anything or plant or animal related to an examination, investigation, test, or inquiry. Where that happens, a warrant can be obtained compelling where there is reasonable probable and grounds to believe that it's necessary, forcing access to, through, or into premises, making examinations, investigations, tests, and inquiries, make, take, or remove samples, copies, or extracts related to examinations, investigations, tests, or inquiries, or to do any such things for the purposes of the Act, required to exercise their power, which is effectively a court order compelling cooperation, where the penalty, instead of a fine, can potentially be jail time for non-compliance. So penalties under the Health Protection and Promotion Act itself for an individual are a fine of up to $5,000 per day of non-compliance. So each day failing to report a communicable disease, each day denying entry, an individual could face a fine of $5,000. And for corporations, it's a fine of up to $25,000, which again is on a per day basis. From my perspective, one of the things that makes the Health Protection and Promotion Act different than other pieces of legislation is the potential for personal liability when an offense is committed. So first, there are personal liabilities directly associated with obligations under the Act. So when I talked about reporting requirements, the reporting requirements are for physicians or superintendents, not the institutions, which means if there is a failure to report, it is not the long-term care home itself that is responsible for the fine. It is the physician, nurse, or superintendent responsible directly for that fine. In addition to those specific requirements on individuals, there can be liability for both a corporation and an individual employee. So where a corporation, for example, fails to comply with an order of the medical officer of health, in addition to the corporation facing fines, an individual employee can, where they are a director of a corporation or an officer, employee, or agent who was in whole or in part responsible for the conduct of the business that gave rise to the offense. So if, from my perspective as a prosecutor, I can prove that you were involved in the conduct that led to the offense, there can be personal liability there. And at that point, it becomes your individual burden to satisfy the court that you took all reasonable care to prevent the commission of the offense. And that is the other way that this act is different than other acts, where it becomes your burden to prove that you did everything you could to prevent the commission of the offense, rather than a prosecutor's burden to prove the opposite. In addition to the Health Protection and Promotion Act, I'm also going to take a brief moment to talk about the Reopening Ontario Act, because it has implications now as well. So this act is the source of many of the public health measures that have been happening since March of 2020. So for example, this is where the actual legal framework for the lockdown restrictions come from. It is where you can find the criteria for the reopening stages. So the stage 1 lockdown requirements, the stage 2, the stage 3. It's where the list of essential businesses and organizations can be found. It's where the mask mandate comes from now. And most of the public health measures now come from this act. The reason I want to talk about it is because it has some general compliance sections that involve the medical officer of health and the health unit. So what I've put up there, one is that businesses are required to ensure compliance with the Occupational Health and Safety Act and its regulations, and also that a business that is open and operating will comply with the advice, recommendations, and instructions of public health officials, including any advice, recommendations, or instructions regarding physical distancing, cleaning, or disinfecting. Subsection 3 also talks about posting signs and screening individuals. So in addition to an order compelling you to do something, this Reopening Ontario Act section requires any business to follow any advice or recommendations that public health makes about appropriate pandemic measures. Lastly, just to tie back into the Chief Medical Officer of Health, there is a similar provision for advice, recommendations, or requirements from the Chief Medical Officer of Health concerning implementation of vaccine policies. And unless there are any questions, that is my presentation.
Wonderful. Thanks so much, Nick. Really good information for all of us to be reminded of. So that does draw us to the end of all of our presentations. Again, feel free if there are any last minute questions that you would like answered to please enter them in the chat box, and we will do our best to get to those questions in real time. But as Jillian shared in her slides as well, she does have a team dedicated to providing answers to any of the questions that you may have. So please reach out to the member of the ID team should you have any specific questions related to COVID-19 outbreaks in your home or anything along those lines. So just on behalf of all the presenters, the staff here at the Grey Bruce Public Health Unit, I would like to thank absolutely everyone for being here, taking the time out of your busy schedules to listen to some of these presentations that we have prepared for you. And again, please reach out if you do have any further questions. We'll be happy to answer those. So I will give it another couple seconds to see if there are any questions that come in the chat box, and I will end the presentation in about 10 or 15 seconds should I not see any questions. Again, thank you very much for attending, and that does draw us to the end of our presentation. Thank you very much for your time, everyone. I do not see any questions coming in, so we will end the presentation now. Thank you.